Hello everyone, welcome to my psychiatric lecture. My name is Dr. Lin. Today we are going to talk about anxiety disorder. So there are 7 types of anxiety disorders described in DSM-5, which are sequenced according to the typical age of onset. So starting from separation anxiety disorder, selective mutism, phobia, social anxiety disorder, or previously known as social phobia, panic disorder, agoraphobia, generalized anxiety disorder. In this lecture, I will be covering the anxiety disorders that are mainly found in adults. So before we dive into each specific anxiety disorder, I would like to explain about the anxiety disorder is that anxiety disorders are disorders that share features of excessive fear and anxiety and related behavioral disturbances. So as an overview. So what is fear and what is anxiety? Fear is the emotional response to real or perceived imminent threat, whereas anxiety is the anticipation of future threat. So these two states overlapped, but they also differ. With fear more often associated with such of autonomic arousal necessary for fight and flights, and thoughts of immediate danger and escape behavior. Whereas anxiety is more often associated with muscle tension and vigilance in preparation for future danger and cautious or avoidant behaviors. So let's start with generalized anxiety disorder. The key features of generalized anxiety disorders are persistent and excessive anxiety and worry about various domains, such as work or school performance, that the individual finds difficult to control. And in addition, the individual experiences physical symptoms such as restlessness or feeling on edge or being easily fatigued, difficulty concentrating, or mind going blank, or irritability, muscle tension, and sleep disturbances. The duration of the symptoms occurring most of the days and at least 6 months. And the individual have their 3 or more of the symptoms that I just mentioned. And the other criteria include the anxiety or worry or the physical symptoms significantly distressing or impairing the patient's social, occupational, or other important areas of functioning. And the disturbances is not attributable to physiological effects of a substance or medication or any other medical condition. And the disturbance is not better explained by another mental disorder, such as panic disorder or separation anxiety disorder or PTSD, etc. So these additional criteria will be included in every anxiety disorder. So I exclude those criteria from my slides. So please keep in mind that we need to consider the remaining 3 criteria in every anxiety disorder. Okay, with that being said, let's move on to panic disorder. In panic disorder, the individual will experience recurrent and unexpected panic attacks, and he or she is persistently concerned or worried about having another panic attack. And there will be changes in his or her behavior by maladaptive ways because of those panic attacks, like avoidance of exercise or avoidance of unfamiliar locations with the fear of having another panic attack. So panic attacks are abrupt surges of intense fear or intense discomfort that reach a peak within minutes and accompanied by physical and or cognitive symptoms. And during the attack, the following symptoms can occur. So the physical symptoms such as palpitation, sweating, trembling or shaking, and sensations of shortness of breath or feelings of choking and chest pain or discomfort, and nausea or abdominal distress, feeling dizzy and steady, lightheadedness or faint, and chills or heat sensations or paresthesia, And derealizations means that feeling of unreality or depersonalization, which is individual feelings like is being detached from oneself, and fear of losing control or going crazy, and the fear of dying. So during the attack, panic attack, the 4 symptoms out of these 13 symptoms can occur. But in limited symptom panic attacks include fewer than 4 symptoms. So the panic attacks may be expected, such as in response to a typically feared object or situation, or unexpected. It can be unexpected as well, meaning that the panic attack occurs for no apparent reasons. Okay, so let's move to another anxiety disorder, which is called agoraphobia. So in DSM-4, the agoraphobia is under the panic disorder because panic disorder can be associated with agoraphobia, or maybe it can occur alone without agoraphobia. Now it is in DSM-5, the agoraphobia is described as a separate disorder. So individuals with agoraphobia are fearful and anxious about the 2 or more of the following situations. So such as using public transportation, being in an open spaces, being in enclosed spaces like elevator, and standing in line or being in a crowd, or being outside of the home alone in other situations. So the individual fears these situations because of the thoughts that escape must be difficult, or help might not be available in the event of developing panic-like symptoms or other incapability or embarrassing symptoms. So these situations almost always induce fear or anxiety and are often avoided and require the presence of a companion. And as usual, the fear or anxiety or the avoidant behaviors cause a significantly distressing or impairment in patient's social, occupational, or other important areas of functioning. And if another medical condition, such as inflammatory bowel disease or Parkinsonism or other important medical condition is present in the patient, the fear, anxiety, or avoidance is clearly excessive than the other, current ongoing symptoms of the medical condition. Okay, let's now turn to another anxiety disorder, which is specific phobia. So it is a situation in which a patient is having fear or anxiety, which is marked fear of anxiety about a specific object or situations, like fear of flying, or fear of heights, fear of animal, fear of receiving an injection, or seeing blood. So everyone can have fear about a specific object or situation, but in specific phobia, the individual will have the marked fear or anxiety, which is so distressing that it can interfere with the functioning. And the phobia object or situation almost always provokes immediate fear or anxiety, and those objects or situations are actively avoided or endure with the intense fear or anxiety. And the fear is out of proportion, and the word is very important, out of proportion to the actual danger posed by the specific object or situation or to the socio-cultural context. Okay, let's now move into social anxiety disorder, in which the individual is fearful or anxious about or avoidant of the social interactions and social situations that involve the possibility of being scrutinized. So these may include the social interactions such as meeting and familiar people, or situations in which the individual may be observed eating or drinking, like partying, and situations in which the individual performs in front of the others. So the cognitive ideation in that kind of patient is that he or she is afraid of being negatively evaluated by others, by being embarrassed or by being humiliated or rejected or offending others. And there is one specific form of social anxiety disorder, which is performance-only type. In performance-only social anxiety disorder, the individual will have fear, which is restricted only to speaking or performing in public, not in other social interactions or social situations. So these anxiety disorders are commonly found in adult patients. So now I have a brief overview for the separation anxiety disorder and selective mutism. So in separation anxiety disorder, the child will have the persistent fear or anxiety about separation from the attachment figures, and it occurs to a degree that is developmentally inappropriate. Which means that at the age of 9 to 12 months, the children can have the separation anxiety. So in separation anxiety disorder, that can go beyond the appropriate age of development. And there is also persistent fear or anxiety about harm coming to the attachment figures and events that can lead to loss or separation from the attachment figures. And they have the reluctance to go away from the attachment figures, as well as the nightmares and physical symptoms of distress can also occur. So in selective mutism, which is characterized by a consistent failure to speak in social situations in which there is an expectation to speak, so such as school, even though the child may speak in other situations such as home. And the failure to speak has a significant consequence on the achievement in academic or occupational settings, or otherwise interfere with the normal social communication. Now we have covered how to diagnose the different anxiety disorder, both in adults and children. Now we are going to talk about management. But the management for anxiety disorders are quite simple. So most of the anxiety disorder are managed with psychotherapy and psychopharmacology, in which the SSRI and SNRI, some SNRI, are the first-line medications. So let's go and see the specific type, okay? So I came up with the generalized anxiety disorder. So first, start with the CBT, cognitive behavior therapy, which is the effective first-line psychotherapy. And the psychopharmacology includes the first-line medications are SSRI and buspirone and some form of SNRI such as venlafaxine XR. And the CBT is very effective and is as effective as a pharmacotherapy. And the evidence does not support the routine combination of CBT and pharmacotherapy. But when the patients do not benefit from CBT, then a trial of pharmacotherapy is advisable, and vice versa. So SSRI, SNRI, we have learned about them in antidepressant chapter. So let's talk about buspirone. So buspirone works by stimulating the 5-HT1A serotonin receptors, and it is mainly used in generalized anxiety disorder. The good thing is that it doesn't cause sedation or addiction or tolerance, so which can occur in terms of using the benzodiazepine groups, right? But the drawback is that it begins to take effect after 1 to 2 weeks, so slower than the benzodiazepine. And it does not interact with other CNS depressant such as alcohol. Okay, so for panic disorder and agoraphobia, they can be treated with the same treatment because, as I said, agoraphobia was included under the panic disorder in DSM-4. So most of their studies are done under the category of DSM-4. So the first-line medications for panic disorder or agoraphobia are also SSRI and SNRI, especially the venlafaxine XR for SNRI. and benzodiazepine, which is not a first-line medication for panic disorder, but because of its rapid symptom control, it can be preferred for patients with very distressing or impairing acute symptoms. In terms of psychotherapy, the CBT, exposure therapy, and psychodynamic psychotherapies are evidence-based, effective psychotherapies. For specific phobia, we cannot give medications for a specific phobia. So cognitive behavior therapy with exposure is the first line treatment. So there are different psychotherapy based on which subjects or which situations that the patient is having phobia against. So for example, like the patient is fearful about heights or flying or spider or claustrophobia, then virtual reality exposure method can be used. For social anxiety disorder, the CBT, cognitive behavior therapy with exposure, is a first-line gold standard treatment. And it is consist of education. So giving education to the patient about the disorder and the treatment, and recommend their self-help materials and exposure. So for anxiety, social anxiety disorder, the patient is provided exposure by role play simulations. And another step is cognitive restructuring, so which is aimed to reduce the negative beliefs about self and others, and works to reduce the excessive self-focus, which is the characteristic in social anxiety disorder, and examines and changes the perfectionistic attitudes, so trying to be a perfectionist. And then we do the social skills training, so which is aimed to deal with any areas of weak social skills, such as eye contact or conversational skills, and address any interpersonal problems, including the lack of social contacts or friendships, and trying to improve their social life, and trying to be more assertive and managing conflicts and dealing with their romantic or problematic relationships. And the final step is the emotional regulation approaches. So include relaxation approaches, including the meditation, mindfulness meditation, and the acceptance of symptoms and anxiety, and being compassionate about oneself and others. So the first line pharmacotherapy for social anxiety disorder are, as usual, SSRI, and in SNRI, venlafaxine XR is the first line, and benzodiazepine, which is the second line, but it can be used at any time in terms of acute and severe symptoms because of its rapid onset. And beta blocker can be used for the performance-only type social anxiety disorder. Okay, so finally we got to separation anxiety disorder and selective mutism management. So as usual, CBT would be the first line mainstay treatment, and in children especially, the psychotherapy prefer over medications. So the fluoxetine, fluvoxamine, and sertraline are the medications that have been studied for separation anxiety disorder in children. But benzodiazepine is never used. And for selective mutism, the exposure is the most important component in CBT in selective mutism. So with that being said, let me just run over the key points again. So we have discussed about the different anxiety disorders, on how to diagnose them and how to manage them. So in terms of management, the CBT, cognitive behavior therapy, is the mainstay psychotherapy option in anxiety disorders. And in terms of medications, the SSRI and some SNRI are the first line. And Pesperol, which is special in a way that it can be used in generalized anxiety disorder and have the special benefits. and beta blocker, which can be used in performance-only type social anxiety disorder. Okay, I hope that you will have gained an insight into the different anxiety disorders. So, thank you very much and see you in the class.